USMLE style question on Charcot-Marie-Tooth disease, CMT. Question. A 15-year-old boy is brought to the clinic by his parents due to difficulty walking and frequent tripping over the past few years. His symptoms have slowly worsened. He also reports weakness in his legs and occasional numbness in his feet. His father had similar symptoms in his teens. On examination, bilateral foot drop, distal muscle atrophy, inverted champagne bottle legs, high-arched feet, cavus, absent deep tendon reflexes in the ankles, reduced vibratory sensation in the lower extremities. Nerve conduction studies show decreased motor nerve conduction velocity. Which of the following is the most likely diagnosis? A. Autosomal recessive disorder leading to progressive degeneration of anterior horn cells. B. Autoimmune demyelination of peripheral nerves following a viral illness. C. Inherited disorder with defective myelin protein production affecting peripheral nerves. D. Toxic neuropathy due to inhibition of snare proteins at neuromuscular junction. E. Autoimmune disorder affecting acetylcholine receptors in the neuromuscular junction. Answer C. Inherited disorder with defective myelin protein production affecting peripheral nerves. Explanation. This patient presents with progressive distal muscle weakness, foot deformities, cavus, and sensory deficits, which are classic findings of Charcot-Marie-Tooth disease, CMT. Key features of CMT: slowly progressive peripheral neuropathy, distal weakness, foot drop, sensory loss. Cavus, hammer toes, due to imbalance of intrinsic foot muscles. Inverted champagne bottle, legs, distal muscle atrophy. Absent deep tendon reflexes due to nerve damage. Family history of similar symptoms, autosomal dominant inheritance. Pathophysiology, defective production of proteins involved in the structure and function of peripheral nerves or myelin sheath. Most common mutation, PMP22 gene duplication, CMT type 1A. Demyelination and axonal degeneration lead to slowed conduction velocity and progressive peripheral nerve dysfunction. Diagnosis: nerve conduction studies, decreased motor nerve conduction velocity due to demyelination. Genetic testing confirms PMP22 gene duplication. Management: supportive treatment, physical therapy, orthotics for foot drop, mobility aids. No definitive cure, but symptoms can be managed to improve quality of life. Why not the other options? A. Autosomal recessive disorder leading to progressive degeneration of anterior horn cells. Describes spinal muscular atrophy, SMA, which presents in infancy with flaccid paralysis and hypotonia, not a slowly progressive neuropathy with cavus. B. Autoimmune demyelination of peripheral nerves following a viral illness. Describes Guillain-Barré syndrome, GBS, which causes acute, rapidly progressive ascending weakness with hyporeflexia rather than slowly progressive distal limb weakness. D. Toxic neuropathy due to inhibition of snare proteins at neuromuscular junction. Describes botulism, which causes flaccid paralysis with autonomic dysfunction, not chronic distal muscle wasting. E. Autoimmune disorder affecting acetylcholine receptors in the neuromuscular junction. Describes myasthenia gravis, which presents with fluctuating muscle weakness and ptosis, not foot deformities and distal sensory loss. Take-home point. Charcot-Marie-Tooth disease is an inherited peripheral neuropathy characterized by progressive distal muscle weakness, cavus, and foot drop due to defective myelin protein production. It presents with decreased nerve conduction velocity and has no cure, but supportive therapy can help.